let's start. Once a wise man said, an ounce of prevention is worth of a pound of cure. I'm an orthopedic surgeon from this hospital. Today we are going to talk about development dysplasia of the hip. It's a spectrum of disorder. It can be from just dysplasia, that means out of shape of the normal hip, and it's a frank dislocation. So it is both ends, complete dislocation, and it's a slight dysplasia. So it's a developmental dysplasia. It's a spectrum, and it comprises instability, acetabular dysplasia, finally subluxation, and then dislocation. So in this spectrum, our patient can present at any stage, from mainly the dysplasia and up to the dislocation, which is very rare, and it is called teratologic hip. So why we are talking about development dysplasia, we miss this happens. So see the young patients with a completely dislocated hip, and one of the this hip is completely arthritic because of the dysplastic acetabulum. See, part of the femoral head is out, and see this is more it's completely subluxate and created pseudoacetabulum somewhere. It created somewhere, and it created acetabulum somewhere else. So because as their bone is very pliable, very growing, so if we give a pressure somewhere else, it will create another acetabulum somewhere else. It's not a good place to be an acetabulum. So then this is a frank dislocation. See, the true acetabulum is completely obliterated by bone and soft tissue, and the hip is somewhere. So they will lose this amount of height in their limb, and they will limp forever, and they will come to us with the severe pain, and we can't do much at this stage. So this is one of the dislocated both bilateral DDH. See, there's a pseudoacetabulum with arthritic and deformed femoral head on both sides. So this is the sequelae. That's why we are gathered here to talk about the development dysplasia of the hip. So this is missed development dysplasia, which lead to adult dysplastic hip with secondary arthritis. So this is the normal hip joint. So which comprises the femoral head and the contoured acetabulum, which covers the femoral head. And if failed to do so, what happened? The femoral head start to subluxate. So when it subluxates, you can see in this image. So the capsule will be stretched, and then there will be, if there are space, then the tissue will grow in and will prevent further relocation, and finally it's dislocate, and it will not allow the acetabulum to grow. So that will be a permanent dysplastic hip in their adulthood. So that's why we are talking about this development dysplasia. So what is the demography? It's very common. It's the most common orthopedic disorder in newborn. Very common. So we are missing too much. So it's very common. So dysplasia is very common. It's 1:100. So 100 birth, there's one incident. And then the dislocation is that is also around common. It's 1:1000. It's equal to CTV incident. So that means it's very common. So that means we are missing. So it's more common in females. Why? They have estrogen. So it make them so lax. So they have more incidents. So, and then in addition to that, because of the anatomic location, left hip is more prone to develop DDH because of the positioning during the fetal life, and bilateral in 20%. So it's very common. We have to know about to prevent the future sequelae and future permanent disability. So the pathophysiology, so when we are talking about the disease, we have to talk about the pathophysiology and the pathoanatomy which related to this condition. So the etiology is initial instability of the hip. So initial instability of the hip, which impinges on the acetabulum, and it prevents the development of acetabulum, and it actually stretches out the capsule. So that's how it started. So it started due to instability. It started from the instability during the fetal life, and then it develops and it prevents the development of the acetabulum. So here you can see this is a normal hip with the complete coverage with the acetabulum. See, the acetabulum is dysplastic and start to subluxate. So what happened because of the subluxation? So one thing, that acetabulum, this part, superolateral part of the acetabulum won't grow. and this femoral head is now in the it's not in the anatomical position, so it won't grow in a proper shape. So that is the problem in this condition. And in addition to that, you can see the ligamentum teres is start to sublux. In addition to that, the capsule will stretches out and it will become a hourglass appearance due to iliopsoas contraction. So when they start to grow, what happened? The iliopsoas attached here from ilia to the lesser trochanter. So what happened? It created an impingement, chronic impingement on the capsule, and which lead to hourglass appearance, which prevent further relocation. So it prevents relocation. So if we miss at this stage, it's very difficult to treat. So then this is the low dislocation, and finally lead to high dislocation. See, they are completely outgrown. It's a completely outer shaped acetabulum with then later they will develop arthritis. So this is the pathoanatomy. This is the same thing which I have discussed, and it can associate it with other conditions. So when you see these packaging deformity, you have to be careful about the DDH. So what is packaging deformities means? Actually, when the fetus got packed up within the tummy of our mother, that means we have to be careful about CTV, we have to be careful about DDH, developmental dysplasia of the hip. So these are the examples: congenital muscular torticollis, metatarsus adductors, congenital knee dislocation. So when you see that, you have to always do the scan for the further, you have to do the further evaluation. So during the evaluation, what we have to know, what we should know is we have to know for the risk factor. So when we know the risk factor, you focus on this condition. So when you know, you will see. So this is the risk factors of firstborn tend to develop DDH, because firstborn tend to develop DDH because why? Tummy is tight. So then female, due to the ligamental laxity, and in addition to that they have estrogen, and then breech presentation, abnormal positioning, and the family history of DDH, and oligohydramnios again tight space, and then macrosomia again tight space, and then limited hip abduction during the delivery. That means they say compared to breech positioning, the single leg breech is more tend to develop DDH, and then talipes. In addition to that, what is this swaddling? This is they are trying to round up a child with some cultures. We don't do because of the environmental temperature. We don't do, but in some kind of area, part of the world, they do swaddling. That means they are wrapping up the child completely in adducted position. So hip, bilateral hip in adducted position, completely tied up. So that means because of that their legs are adducted. So because of that, it is creating a lot of pressure on the lateral part of the acetabulum. So now the nurses in that part and the midwives in that part, they are educating about the swaddling in abducted position. So in neonatal examination, this is the first line of defense. If it miss, that means miss forever in our setup. That's the problem. So in neonatal examination, this is the most important thing. So we have to do the Barlow's and we have to do the Ortolani test. So what is Barlow test is we dislocate. We dislocate the dislocatable hip. That means we adduct, and push posteriorly. We push posteriorly. That means we have to hold the knee between our first web space. We have to hold the knee within the first web space and keep our index and middle on the trochanter and the thumb on the medial part of the thigh. And then we adduct the leg and push outside. That is called Barlow test. That is dislocate the dislocatable hip. And what is Ortolani? This is O. So remember this. O means hip. So inside the hip. O means round, means hip. That is inside the hip. Ortolani means relocate. So what we do is we abduct and give an anterior pressure. So with the same hand, with the same position. So we adduct and push and dislocate and see the Barlow. The Ortolani is we relocate into the hole. That means we relocate into the O. So that means Ortolani. That means abduct and give an anterior pressure. So that is the neonatal examination. So this is the first line of our defense. So the people who are doing neonatal examination should be very careful not to miss these tests. If you suspect, then you have to go for a second line of power defense. So this is the third test. This is called Galeazzi. So see, the femur is short compared to the right leg. So for this, to this assessment, child should be old enough to do this. So the second line of defense. This is the second line of defense is ultrasound. So indication is primary imaging. This is the primary imaging because they are full of cartilage. So child hip is full of cartilage. We can't see femoral head. We can't see acetabular. So if anyone doing X-rays before 4 to 6 months, it's absurd, completely absurd. So completely we are depends on ultrasound scan. So the indication is primary imaging modality, nothing else. Primary imaging modality. If you suspect and if you see any risk factor, you do the examination. Even if you don't see, you go for the second line of defense to find out the thing. So when we are doing other things, mainly I would advise you, it's a primary imaging modality. So and then it's definitely indicated for positive examination, and in the presence of risk factor we have to do. So we evaluate the acetabular dysplasia. They have angles, alpha angles, beta angles. They measure, and then according to that they grade. So whatever the grade, whatever the degree, we better to go for a treatment. That means better to go for the treatment. We will come to that later. So if we find out better to go for the treatment, why, we will come to that later too. So the thing is, even in the normal ultrasound in a patient with soft tissue clicks, they say if it's normal, and if the child has risk factors and the clicks and the first ultrasound is normal, you go for the second as well. And better to do the re-examination. So when we talk about the evidence, they are talking about the re-examination during the time. But in our setup, it's not possible. If we miss these two defenses, that is not possible. They won't come back. So they will come back when they start to limp. So that is a problem in our setup. So we can't imply everything what in the Western they are practicing. It's not possible because they won't come after these two defenses. So best thing is to, if you suspect, you do the ultrasound. Low tendency to have ultrasound. So they are talking about the alpha angles and beta angles. Radiologists will guide you, and they will do, and they will grade you, and they will send you for the clinic. So radiograph is for the later stage after 4 to 6 months. So what are we going to look at the radiograph? So there are two lines we are talking about. So one thing is horizontal edge. So it is through the triradiate cartilage. So Hilger-Reiner line. So we are drawing a line through the triradiate cartilage. See, this is the triradiate cartilage. So through that horizontal line, edge. So then we are talking about another line, Perkins line. So that is vertical on the lateral part of the acetabular. So the hip should be within the inferior medial part of this quadrant. So it should be there within this quadrant. So see, this is dislocation. And third line is called Shenton line. So that means medial part of the neck and the head and the medial part of the femur should inline with the inferior part of the superior pubic gland. So that is called Shenton line. Here it is broken because of the dislocation. So it is dislocate. So this Shenton line broken in a lot of other situations, means hip dislocation, fractures and everything. But here we have to talk about these two lines. Importantly, these two lines. In addition to that, there is another thing is called acetabular index. So this is H line, Hilger-Reiner's line, and from the midpoint we draw another line through the lateral part of the acetabular, and we measure this angle. This is called acetabular index. This should be less than 25 at the age of 6 months. So that is our target. So until then, we screen with the ultrasound scan with the brace. So we will talk about later. So these are the radiology parameters. That's why we are breaking our heads here in the morning. So to learn more about the developmental dysplasia of the hip, and it is very serious.